Okay. Hello, everyone. I'm Thomas Johnson, President and CEO of Medicaid Health Plans of America, or MHPA. I'm pleased to join HMS to co-present today's webinar with the Association for Community Affiliated Plans, or ACAP. Today's topic is an important one, helping MCOs prepare for Health and Human Services, HHS, Inspector General Oversight reviews. During the webinar, all lines will be muted to avoid any background noise. If you'd like to ask a question, please do so at any time during this presentation. Simply use the Send Question to Staff feature in the control panel. We'll address your questions at the end of the presentation. Since the passage of healthcare reform over a year ago, the amount of scrutiny and sheer number of review programs aimed at MCOs has increased exponentially. Medicaid RACs, State Office of Controller and Medicaid Inspector General Work Plan, CMS audit, MICs, and other state contracted vendor efforts will all be looking at MCOs to determine whether they're doing all they can to ensure Medicaid program integrity. Often these efforts can overlap and create an added administrative burden on plans to coordinate review findings. Today's focus is on the upcoming reviews conducted by the HHS Inspector General. By anticipating review requirements and making proactive adjustments, MCOs may avoid some of the challenges of coordinating changes to their plans after the reviews are completed. Our objectives for today are threefold. First, to explain what MCOs need to know about the 2011 Inspector General Work Plan. Second, to discuss how MCOs should prepare for the review. And third, to offer next steps which MCOs should take to make plans review ready. Joining me to address the issues are Phyllis Hartstein, HMS Vice President for Managed Care Business Unit, and Deborah Kilstein, ACAP's Vice President for Quality Management and Operational Support. Now, Deborah will give us a brief overview of the Office of Inspector General, or OIG, work plan. Deborah?
Thanks, Thomas. The Office of Inspector General is mandated by law to protect the integrity of HHS as well as the health and welfare of beneficiaries under HHS programs. The Inspector General is required to report any program and management problems to both the HHS Secretary and to Congress, and to make recommendations to correct these problems. To identify problem areas, the Inspector General conducts audits, reviews, investigations, and evaluations on the plethora of programs that fall under HHS's jurisdiction, and that includes the Medicaid program. Each year, the Inspector General's office publishes a work plan outlining the various projects within each of its major entities, CMS, the public health agencies, and the administrations for children, family, and aging. For each review, the work plan describes the subject, the primary objective, and the criteria. Once a review is complete, the Inspector General publishes a report that summarizes findings and makes recommendations, including any monies that must be returned to the federal government. This plan is a good document for entities such as Medicaid managed care plans to look at in order to prepare for these reviews. We're aware that the Inspector General has already initiated some reviews within the 2011 work plan, which is why we're holding this webinar today. MCOs should know about the reviews within the work plan that specifically relate to Medicaid managed care plans and begin to prepare. You can find a link to the full 2011 Inspector General work plan on HMS's website, which is hms.com/webinar. You'll see that the work plan is divided into several major parts. Part 3 deals with Medicaid and will be the focus of our webinar today. Now, Phyllis will discuss the areas of specific interest to Medicaid managed care plans. Phyllis?
Thank you, Deborah and Thomas. Let's start with the Inspector General's first area of focus, state oversight of MCOs' provider credentialing methods. To be sure that enrolled providers have the right credentials, the Affordable Care Act, and by the way, I'm going to refer to that as the ACA from here on, requires that all providers be subject to regular licensure checks, which could include checks across state lines. CMS may take this mandate one step further and require additional credentialing procedures, including criminal history checks based on the risks associated with particular provider types. The ACA also calls for increased oversight of new providers for specific periods after they enroll. It also requires additional scrutiny of initial claims submitted by new durable medical equipment and prosthetics, orthotics, and suppliers, also known as DME. HHS is also requiring providers to include their National Provider Identifier, or NPI, on all Medicare and Medicaid enrollment applications and claims. On February 2, 2011, CMS and the Inspector General published a final rule implementing these new screening procedures. CMS also has its own rules for provider credentialing oversight. For Medicare, there are levels of risk for provider types, with home health care and DME at the highest level. Each level will be subject to stringent screening requirements to reduce specific risks associated with provider types. CMS will also require state Medicaid agencies to establish categorical levels of risk for their providers. For moderate and high-risk providers, state agencies must conduct site visits. High-risk providers will also be subject to fingerprinting and criminal background checks. Additionally, CMS began requiring suppliers to meet new enrollment standards in 2009 and finalized these standards in August of 2010. Finally, the ACA now requires Medicare and Medicaid providers to establish compliance programs that adhere to standards set by both CMS and the OIG. CMS is developing additional requirements for these compliance programs. CMS and state agencies may declare a moratorium on enrollment of new providers if they determine that it's necessary for preventing and combating fraud, waste, and abuse. The next area of focus is provider enrollment. Provider enrollment is one of the most vulnerable areas of Medicaid. CMS forbids plans from employing or contracting with providers who are excluded from participation in federal health care programs. However, despite the plan's best efforts to comply, problem providers still manage to slip in unnoticed. Strengthening enrollment standards and procedures is a very important step toward reducing the risk of enrolling entities intent on defrauding the program. Therefore, the ACA clearly addresses the need for stricter monitoring of provider enrollment in both Medicare and Medicaid. Specifically, the Act mandates that providers take a more active role in demonstrating the particular actions they're taking to promote the integrity of the Medicaid program. For example, the continued inclusion of deceased providers is an issue that MCOs must address. The Government Accountability Office, or GAO, has determined that neither states nor MCOs have an effective method for identifying the deaths of Medicaid providers. Deceased providers' numbers are frequently used to bill for services long after the provider's date of death. This type of fraud is relatively easy to catch and stop if the right approach is taken. The GAO also believes that Medicaid state standards do not sufficiently protect Medicaid programs from excluded providers. This belief stems from a September 2009 report which found that in 5 states, Medicaid paid over $2 million for controlled substances that were written or filled by 65 doctors or pharmacies who were barred or excluded from federal health care programs. These providers had previously been found guilty of a wide range of offenses, including the illegal sale of controlled substances. As such, the ACA now requires providers to disclose all affiliations, past and present, with other providers who have uncollected debt, who are or were subject to a payment suspension under a federal health care program, who have been excluded from participation in Medicare, Medicaid, or CHIP, or who have lost their billing privileges in a federal program. Finally, providers that order DME prescriptions or home health services must currently be enrolled in Medicare or Medicaid and must also maintain record of these orders. The claims they submit for these services must also include their provider identification number. As indicated in a Federal Register released on February 2nd of this year, HHS will not impose additional screening or enrollment criteria on MCOs. However, MCOs will be obligated to develop their own unique screening requirements, including assigning providers and suppliers to a level that is higher or lower than the one assigned by Medicare or the Medicaid program. MCOs must be able to determine whether enrolled providers have satisfied these requirements. Furthermore, the Act now requires all plans to develop written policies and procedures for selecting and retaining providers. Each plan must also document its processes for credentialing and re-credentialing providers that have signed contracts or participation agreements. States may also begin requiring MCOs to check the list of excluded individuals and entities and the excluded parties list system on a monthly basis to determine whether providers, employees, and contractors have been excluded. To ensure compliance, the Inspector General will review these plans to determine if they are contracted with excluded providers to provide services, or if any entities in an MCO's provider network employ excluded providers. The Inspector General will also review how states oversee plans compliance with these mandates. In the face of CMS and state requirements, we recommend that plans do the following. Obligate enrolled providers to adopt written compliance programs that meet the mandated requirements. Evaluate credentialing and enrollment standards and processes to make sure they meet the federal standards, and revise them if they don't. Evaluate their own policies and procedures for identifying excluded or other problem providers in their network on a regular and frequent basis. Implement consistent methods to be sure claims are only paid to eligible providers. Make sure that the provider databases contain all the basic provider information